Imagine you're standing in the middle of a massive, just dimly lit library.
Okay.
There are millions of books, right? Billions of words on those pages. And your job is to find a single, very specific, misspelled word hidden somewhere in one of those books.
Oh, wow. Good luck.
Right. And you're on a ticking clock. Because if you find that misspelled word early, you've got about a 50% chance of fixing the problem.
Yeah.
But if you find it late, your chances just, well, they plummet to a dismal 5%.
It's an incredibly daunting task, to say the least. But, in the world of oncology, that is exactly the challenge clinicians face every single day with early detection.
Yeah.
The sheer volume of tissue in the lungs, combined with the microscopic origin of the disease, it makes finding the initial anomaly feel almost impossible sometimes.
And for the medical students, young professionals, or really just the curious learners joining us today,
Yeah.
that library analogy is kind of the foundation of what we're unpacking. We are doing a deep dive, pulling entirely from the comprehensive textbook, Lung Cancer and Imaging. We're walking through the entire clinical pipeline. So epidemiology, advanced imaging techniques, all the way down to, molecular biomarkers and these wild next-generation localized treatments.
Yeah, and to really ground us in reality here, we have to look at the 2018 statistics the source text provides.
Lay 'em all us.
We are talking about roughly 2.1 million new cases worldwide and 1.8 million deaths just in a single year.
Wow.
I mean, it is the leading cause of cancer-related mortality globally. And of all those cases, about 85% fall into the category of non-small cell lung cancer, or NSCLC.
Okay, so if the stakes are that high, and finding that misspelled word early is, the only real way to improve survival rates, we clearly need better flashlights in that dark library.
Right, absolutely.
And for a long time, the standard flashlight was just a basic chest X-ray. But the medical field has fundamentally shifted, right, toward low-dose computed tomography, or LDCT. Why did we abandon the standard X-ray?
Well, the shift was largely driven by the National Lung Screening Trial, the NLST.
Okay.
That trial was a total watershed moment because it proved that screening high-risk populations with LDCT reduces lung cancer mortality by 20%.
20%. Just from changing the scan.
Yeah, compared to traditional X-rays, a 20% reduction in mortality for the world's deadliest cancer is a staggering victory.
That's massive.
Because, LDCT provides these three-dimensional cross-sectional views of the lungs. It allows us to see abnormalities that a standard flat X-ray would simply flatten and obscure.
Right, because an X-ray is basically a shadow.
Exactly.
Now, to make sure every doctor is reading those 3D scans the same way, the text mentions the American College of Radiology developing the lung RA's assessment categories.
Yes, very important standardization.
So like a category 1 is completely negative, and it scales all the way up to 4X, which is highly suspicious with malignant features. But even with this standardized system, radiologists still run into this massive roadblock, which are ground glass opacity nodules, or GGOs.
Oh, GGOs. They're the bane of a radiologist's existence. I mean, they show up on the scan as these hazy, really indistinct lesions.
Like an actual ground glass.
Literally like a piece of frosted glass hovering in the lung tissue. You can actually still see the underlying architecture of the lung, the blood vessels, the bronchia right through the opacity.
But why are they so hazy? Like, what is physically happening in the tissue that causes that specific visual effect?
Well, the haziness happens because something is partially filling the air spaces in the lungs, or maybe thickening the walls of the alveoli, but it's not completely destroying the tissue structure yet.
Okay, something.
Right, and that something is the problem. I mean, a GGO could be slow-growing adenocarcinoma cells just creeping along the alveolar walls.
Which is bad.
Very bad. But it could also just be a focal area of inflammation, a mild infection, or even, a tiny hemorrhage from a bad coughing fit.
Wait, really? So a radiologist looking at a screen is trying to distinguish between a life-threatening early cancer and a leftover cough, just based on a blurry gray shadow.
Pretty much. Add in visual fatigue from looking at hundreds of slices per scan, and you can see why classifying GGOs is a critical vulnerability for human eyes.
Okay, let me push back on something here, though.
Sure.
If LDCT drops mortality by 20% and catching these ambiguous GGOs early is the whole game, why is screening restricted? I mean, why aren't we just putting every adult over 30 through an LDCT scanner every single year.
Ah, well then you run straight into the dangers of overdiagnosis and false positives.
Which means what exactly for the patient?
It means if we screen the entire general population, we are going to find millions of tiny, benign GGOs. And every time you find one, it triggers intense patient anxiety. It requires follow-up scans with more radiation exposure.
Right.
And most dangerously, it often leads to invasive surgical biopsies. And a biopsy in the lung carries severe risks. It could easily collapse the lung.
Oh, wow. So the harm of the medical intervention would actually outweigh the benefit of the screening.
Exactly. You'd be injuring thousands of perfectly healthy people just to find a single tumor.
That makes sense.
Yeah, this is why screening guidelines specifically target high-risk adults, typically aged 55 to 80, with at least a 30-pack year smoking history. We're trying to maximize the hit rate of true positives.
Okay, so if human eyes are physically incapable of distinguishing a tiny hemorrhage from an early cancer on these scans, how do we prevent those false positives within that high-risk group? Do we just need like 8K resolution monitors?
No, a better screen won't fix human visual limitations. We need a completely different way of processing the data. The source material outlines the evolution of AI in this space. We're moving from basic computer-aided diagnosis into what is now called radiomics.
Radiomics, and that's essentially the extraction of hidden quantitative data from medical images, right?
Yeah.
Data that the human eye literally cannot perceive.
Exactly. Think of it like this. Imagine looking at a black and white photograph of a sandy beach.
Right.
You just see a general gray texture, but a computer can calculate the exact statistical variation of every single grain of sand, the mathematical patterns of light and dark.
It's counting the grains.
Basically, yeah. And the textbook details some incredibly sophisticated models doing this for lung nodules. They highlight a framework combining a seventh-order Markov Gibbs random field model, an MGRF, with 3D convolutional neural networks.
Okay, hold on. A seventh-order MGRF sounds like something out of a theoretical physics dissertation.
Yeah.
What is that actually doing to a lung scan?
It sounds intimidating, but the MGRF is just a mathematical model that maps spatial inhomogeneities.
In plain English, please.
Right, sorry. In plain English, it analyzes how likely a certain shade of a pixel is to be located next to another specific shade. It finds the mathematical patterns of chaos and unevenness inside the nodule.
So while I just see a gray blur, the MGRF is mapping a statistical texture.
Precisely. And then the 3D CNN extracts the local structural features based on that map.
And when they let this combined AI model loose on the Public Lung Image Database Consortium dataset, the results were just wild. I mean, it hit a 92.9% diagnostic accuracy, 91.39% sensitivity, and 94.04% specificity.
Those numbers represent a monumental shift. But, traditional 3D CNNs still have blind spots, which is why researchers are now exploring capsule networks, or CAPS-nets.
I really want to make sure I understand CAPS-nets, because the concept here is fascinating.
Go for it.
If you think about a traditional CNN looking at a human face, it essentially uses a checklist, right? It scans the image and says, I see eyes, I see a nose, I see a mouth, check, check, check. This must be a face.
Right.
But it doesn't care where those parts are. If the mouth is on the forehead, the traditional CNN still checks the boxes and calls it a face.
That is the fatal flaw of traditional pooling layers in a CNN, yes. They completely lose spatial relationships.
So a capsule network fixes that by checking the arrangement. It understands spatial hierarchies. It knows that the mouth must be below the nose. And for something as messy and unstructured as a ground glass opacity, knowing the exact spatial relationship of those textures is everything.
It's a critical upgrade. And the broader implication here is that AI is not replacing the radiologist.
Oh, sure.
It's acting as a hyper-precise filter. It shifts the paradigm from subjective visual interpretation, where two doctors might totally disagree on a blurry shadow, to objective, data-driven precision medicine.
But AI still relies on the data we feed it. And right now we're feeding it CT scans, which require a massive, expensive machine and expose the patient to ionizing radiation.
Yeah.
I mean, we can't put a patient in a CT scanner every single week to monitor a suspicious nodule.
No, absolutely not.
So are there entirely different non-ionizing ways to gather this data?
Yes. The sources outline 3 highly innovative alternative diagnostic tools that bypass the traditional CT. The first one enhances an existing procedure, bronchoscopy, with image processing.
Okay, what are they doing differently there?
They combine autofluorescent imaging and white light bronchoscopy, and then use an algorithm to extract features in the HSV color space. That stands for hue, saturation, and value.
Wait, why specifically HSV? Why not just standard RGB color, like a television or a computer monitor?
Because the inside of a lung is wet, dark, and highly reflective.
Ah,
If you use RGB, a bright reflection from the camera's flashlight looks like a completely different tissue type to a computer. It messes up the data. HSV separates the actual color, the hue, from the lighting intensity, the value.
oh, that's clever.
Right. This allows the system to accurately classify adenocarcinomas versus squamous cell carcinomas right there in the airway, completely ignoring the glare from the camera.
That is brilliant. The text also covers electromagnetic, or EM, imaging, like electrical impedance tomography and microwave imaging. Instead of shooting radiation through the body, these map the dielectric properties of tissue.
Yes. The core principle here is that a malignant tumor has vastly different electrical conductivity and permittivity compared to healthy, air-filled lung tissue.
Because it's solid.
Because tumors are dense with cells and have a much higher water and blood content. EM imaging capitalizes on that physical contrast without using any harmful radiation at all.
And the third alternative is something I hadn't even considered possible. Exhaled aerosol fingerprints. It's literally a non-invasive breath test.
Yeah, it's amazing. As you breathe out, the system analyzes the patterns of exhaled aerosols.
How does that find cancer, though?
It detects airway remodeling. If there's a growing tumor or even asthmatic bronchioles altering the physical shape of your airway, it changes how the air flows through your lungs. The aerosol fingerprint shifts, and the algorithm catches the aerodynamic disruption.
Wait, if these tools are so effective, are we eventually going to just throw away our multi-million-dollar CT machines? Are we just going to have patients breathe into a tube or use microwaves?
No, because they serve entirely different functions. These are complementary tools. EM imaging is radiation-free, making it perfect for continuous, safe bedside monitoring. You can literally watch a tumor shrink in real time over weeks.
Oh, wow. And the breath test.
The exhaled aerosol fingerprints. That offers a rapid, highly accessible triage tool in a primary care setting. It helps a general practitioner decide who actually needs to be sent to the hospital for the expensive radiating CT scan.
It's all about building a smarter pipeline.
Exactly.
Now, let's say our imaging tools and our AI have successfully located and diagnosed a malignant tumor. The mission changes. We have to figure out exactly what kind of enemy we're fighting. We have to zoom all the way in from the macroscopic scan to the microscopic biology.
We are crossing into the molecular fingerprint. Historically, oncology treated lung cancer purely by its anatomical stage, like how big is it and where has it spread?
Right, stage 1, stage 4, etc.
Yeah, exactly. But now the focus is personalized medicine based on histological and molecular subtypes. The textbook spends a lot of time on genomics, particularly EGFR mutations.
The epidermal growth factor receptor. The data shows these mutations are most common in Asian populations, in women, and notably in never smokers.
Yes, that's a key demographic.
If a patient has this mutation, the standard of care is tyrosine kinase inhibitors, or TKIs, things like afatinib or osimertinib. I like to visualize EGFR like a stuck doorbell on the outside of the cancer cell. It's constantly ringing, sending a signal into the house saying, grow and divide, grow and divide.
That's a great way to picture it. And the tyrosine kinase inhibitor is the intervention.
Right, the TKI is like jamming a thick piece of tape over the internal wiring of that doorbell. It physically blocks the receptor from binding with ATP, which is the cellular energy it needs, to actually transmit that growth signal into the nucleus. The doorbell is technically still stuck, but the house can't hear it anymore.
And the tumor stops growing.
Incredible.
It is. The text also notes other crucial genetic targets like ALK and KRAS rearrangements, but beyond genomics, we have to look at metabolomics. This involves the Warburg effect, which is just fundamental to how cancer survives.
This is where cancer cells alter their metabolism, right? They ramp up glycolysis. But why would they do that if oxygen is present? Normal cellular respiration is much more efficient at making energy than glycolysis.
It is less efficient for pure energy, but cancer cells aren't just trying to survive. They're trying to duplicate rapidly. Glycolysis provides the intermediate building blocks, the carbon skeletons needed to build new cells.
Oh, they need the raw materials.
Exactly. And because of this massive shift, we can look at a patient's biofluids and see a distinct metabolic signature, an increase in lactate and ketone bodies, and a severe decrease in glucose.
And that signature becomes a powerful biomarker for cancer presence and progression. But the most mind-bending part of the molecular section, for me at least, was immunotherapy. Specifically PD-1 and PD-L1 checkpoint inhibitors. These drugs essentially take the brakes off the patient's own immune system so it can attack the cancer.
The mechanism relies on understanding tumor mutational burden, or TMB. And the source material highlights a clinical paradox here that challenges a lot of assumptions about patient outcomes.
This genuinely stopped me in my tracks. We all know heavy smoking causes lung cancer by severely damaging DNA.
Yes.
But paradoxically, because that heavy smoking history severely damages the DNA, it creates a tumor with a massively high mutational burden.
The tumor cells look incredibly chaotic. I mean,
Yeah.
they are covered in mutant proteins that just don't look human anymore.
And because they look so genetically chaotic and alien, the immune system is actually much more easily awakened by checkpoint inhibitors to fight them. It can spot the enemy clearly. So, ironically, a heavy smoker with a massive amount of genetic damage often has a much better response to immunotherapy than a non-smoker whose tumor looks genetically similar to healthy tissue.
It is a profound paradox. The very thing that caused the disease provides the vulnerability we use to treat it.
But, immunotherapy and targeted TKIs rely on systemic delivery. They go through the whole body.
Yeah.
What happens if the tumor is unresectable, meaning surgery is too dangerous, or the tumor is resistant to drugs, or the patient is just too weak for systemic treatments?
That brings us to the final frontier in the text. Next generation, localized synergistic treatments. These therapies are designed to obliterate the tumor without poisoning the rest of the body. First is photodynamic therapy, or PDT.
Wait, using light to kill the cancer?
Indirectly, yes. We inject a photosensitizer drug that selectively accumulates in the tumor tissues. Then we hit the tumor with a very specific wavelength of light, usually delivered via an optical fiber during a bronchoscopy.
And what does the light do?
The light activates the photosensitizer to produce singlet oxygen. That's a highly reactive and toxic molecule that kills the cancer cells right there locally.
Wow. Then there is cold atmospheric plasma, or CAP, combined with magnetic iron oxide nanoparticles.
Yes, this one is fascinating.
The CAP delivers reactive oxygen species and reactive nitrogen species directly to the tissue. And when combined with drug-loaded iron oxide nanoparticles, they achieve a massive synergistic effect, inducing apoptosis and necrosis specifically in the lung cancer cells.
Right.
Let me make sure I'm visualizing this CAP and nanoparticle synergy correctly. I was originally thinking of it like the nanoparticles are microscopic Trojan horses delivering a payload, while the cold plasma acts as an invading army breaking down the cell walls.
Well, the Trojan horse aspect for the nanoparticles is accurate, as they do deliver the drug directly inside. But think of the cold atmospheric plasma less like an invading army and more like targeted rust.
Targeted rust.
Yeah. The reactive oxygen species from the CAP oxidize and degrade the lipid membranes of the cancer cells. Healthy cells have really robust antioxidant defenses and can just shrug off this rust. But cancer cells are already under high oxidative stress. The CAP pushes them over the edge. It degrades their armor just as the nanoparticle Trojan horses deploy their payloads inside.
That makes so much more sense. It's exploiting their existing stress.
Exactly.
And lastly, the text details thermal electromagnetic ablation. This uses radio frequency around 400 to 500 kilohertz and microwave energy up to 2.45 gigahertz to physically heat the tumor tissue to between 50 and 60 degrees Celsius.
Right, and at that temperature range, you cause rapid protein denaturation and coagulation. You are effectively cooking the unresectable tumor in place. It destroys the malignant tissue while leaving the surrounding healthy lung intact.
The progression here is just incredible. I mean, we started with the sheer epidemiological scale of the problem and the necessity of finding the misspelled word with LDCT screening.
Right.
We saw how AI, through MGRF models and capsule networks, is decoding the blurry textures of GDOs. We moved past the CT scan into EM imaging and exhaled aerosol breath tests. We decoded the molecular biomarkers, marveling at the paradox of tumor mutational burden.
Still blows my mind.
And finally explored localized treatments like cold atmospheric plasma and thermal ablation.
The entire textbook really paints a picture of a clinical pipeline that is becoming hyper-precise at every single stage.
Absolutely. Now, since we have so many medical learners listening, let's pull all these concepts together with a practical scenario for you all. Let's say you're on rotation and you are reviewing the chart of a newly admitted 65-year-old female patient.
Okay, 65.
She is of Asian descent and a lifelong non-smoker. Her chart says she presents with a Category 4A lung radius nodule. Based on what we've unpacked today, what specific imaging modality likely detected and classified this nodule? And if a biopsy confirms it is an adenocarcinoma, what specific genetic mutation should she immediately be screened for to guide her targeted therapy?
All right, if we follow the clinical pathway we outlined, the 4A lung radius classification means the nodule was definitely detected and standardized via a low-dose computed tomography, or LDCT scan.
Yep. And because she fits the specific demographic profile, an Asian female and a non-smoker with adenocarcinoma, she absolutely must be screened for the EGFR mutation.
Crucial step.
If she tests positive, her care team can bypass systemic chemotherapy and treat her directly with tyrosine kinase inhibitors, blocking that stuck doorbell.
It perfectly illustrates how epidemiology, advanced imaging, and molecular biology
Yeah.
all converge to dictate a single patient's care plan.
But I want to leave you with a final thought, going all the way back to our starting analogy.
Right.
We talked about the monumental task of finding that single misspelled word in a giant, dark library.
Right.
As our AI models, our radiomics and our aerosol breath tests become increasingly just unbelievably flawless at detecting microscopic abnormalities, we are inevitably going to find tiny nascent cancers.
Yeah.
Cancers so incredibly small that historically the human immune system might have just quietly cleared them away on its own without the patient ever feeling a symptom.
It forces the medical community to constantly reevaluate the threshold of intervention.
Exactly. When our flashlights get too bright and our AI too perceptive, we have to ask, at what point does the absolute miracle of early detection cross the line into the harm of overdiagnosis? Do we risk tearing apart the library just to fix a typo that didn't even matter? It's a philosophical and medical boundary to mull over as you step back into the clinic. Thanks for diving into the clinical pipeline with us.